The fluorescent lights of the emergency department cast a sterile glow over Bay 3. Mr. Henderson, a man in his late 60s, had been admitted earlier with complaints of general malaise and shortness of breath. His initial observations were concerning, but not immediately alarming, and the team had been working to stabilize him. Suddenly, a seasoned nurse performing routine checks leaned closer to Mr. Henderson, her brow furrowed. She reached for his wrist, her fingers pressing firmly to palpate his radial pulse. Nothing. She quickly moved to his neck, searching for the carotid pulse. Again, an unnerving stillness met her touch. "I can't feel a pulse," she announced, her voice cutting through the low hum of the department. "Starting compressions! Call a code blue, Bay 3! The familiar urgent call echoed, signaling a life-threatening event was unfolding rapidly. The resuscitation team converged on Bay 3 within seconds, a whirlwind of focused activity. The code cart, laden with life-saving equipment and medications, was wheeled into position. As chest compressions began, rhythmic and forceful, another team member glanced at the cardiac monitor. The display remained unchanged. It still showed that same organized electrical rhythm. The stark contradiction was jarring. The screen proclaimed a functioning electrical system, yet the patient lay pulseless. The lead physician, Dr. Ramirez, quickly assessed the situation. "We have an organized rhythm on the monitor, but no palpable pulse," she stated clearly. "This is PQ pulseless electrical activity." The urgency intensified. They weren't just fighting a misfiring electrical circuit, they were fighting a silent mechanical shutdown. Pulseless electrical activity, or PEA, represents one of the most deceptive and dangerous cardiac arrest rhythms. It is characterized by an organized electrical rhythm on the electrocardiogram, yet the patient presents without a detectable pulse and shows no signs of circulation. The heart might be electrically alive, but it is not mechanically pumping blood to the vital organs. The ECG can display a rhythm that looks almost normal, but in PEA this expected correlation breaks down completely. The electrical activity continues, but the heart muscle itself is either too weak, too restricted, or facing an overwhelming obstruction that prevents it from ejecting blood. To effectively combat pulseless electrical activity, medical professionals rely on a systematic approach to uncover its potential triggers. These are often memorized using the mnemonic, the H's and T's, which provides a checklist of common reversible causes of PEA. The H's represent a group of 6 potentially reversible conditions: hypovolemia, hypoxia, hydrogen ion, acidosis, hypokalemia, hypoglycemia, and hypothermia. Complementing the H's are the T's: toxins or tablets, tamponade, tension, pneumothorax, thrombosis, heart attack, thrombosis, pulmonary embolism, and trauma. Each of these 12 conditions creates a scenario where, despite potentially normal electrical signaling, the heart is physically unable to generate a pulse and circulate blood. For instance, in cardiac tamponade, the heart is literally being squeezed, so it cannot fill adequately between beats. In a massive pulmonary embolism, the right ventricle pumps against an insurmountable blockage. In severe hypovolemia, the pump is primed with insufficient fluid. Therefore, the presence of an organized rhythm on the ECG in a pulseless patient should immediately trigger a rapid search for these H's and T's. When a patient is in pulseless electrical activity, the information displayed on the cardiac monitor can be a dangerous distraction if it becomes the sole focus of treatment. Unlike shockable rhythms, PEA does not typically respond to defibrillation. The problem lies in the heart's inability to mechanically respond to these signals, or in an external factor preventing effective circulation. The core principle in managing PEA is that treatment must be directed at the underlying reversible cause. High-quality cardiopulmonary resuscitation, CPR, is essential to maintain some blood flow to the brain and heart, while the team works to diagnose and treat the specific problem. Consider a few examples. If hypovolemia is suspected, the immediate treatment is rapid administration of intravenous fluids or blood products. If a tension pneumothorax is the culprit, a needle decompression or chest tube insertion is urgently required. For suspected hypokalemia, medications like calcium chloride, insulin, and glucose are administered. Each of the H's and T's has specific interventions. The Advanced Cardiovascular Life Support (ACLS) protocols provide a structured algorithm for managing cardiac arrest, including PEA. A pulseless electrical activity stands as a stark reminder in emergency medicine that what we see on a monitor is only one piece of a complex puzzle. Its deceptive nature can easily lead clinicians down the wrong path if they are not vigilant and well-informed. Mastering the recognition and management of PEA is a fundamental skill that directly impacts patient survival. This involves more than just memorizing the H's and T's. Effective training plays an indispensable role in preparing medical teams to handle PEA scenarios. High-fidelity simulations, regular code blue drills, and ongoing education in ACLS protocols are essential. Teamwork and clear communication are also honed during these simulations. When the heart lies by showing electrical life without mechanical function, it is the skill, preparedness, and critical thinking of the resuscitation team that can uncover the truth and offer the patient their best chance at life.